And now I have the pleasure to invite Professor Petar Seferovic, the president of the Heart Failure Association of the ACC. Professor Seferovic is academician, Serbian Academy of Science and Arts. He's a professor of cardiology at Belgrade University School of Medicine, as well as the president of the Heart Failure Society of Serbia. And Professor Petar Seferovic is going to talk about a very interesting topic, which is the conundrum of the new anti-diabetic drugs in treatment of heart failure. Professor Petar.
So I'm really happy to be here. As I said, I feel that I'm among friends because we had a lot of activities together. And as we exchanged the opinion before starting the webinar, I think that that's the way to go. In terms of connecting Heart Failure Association as a biggest global heart failure organization with the Middle East, and we already had an excellent opportunity to work with all of you. And I would like to congratulate you on the first Pan-Arab Summit, which is, by the way, one of the first online summits in the ESC. So you were the faster one, and that means a lot. I don't need to tell you that heart failure is frequent, that it is progressive, that is absolutely deadly, and it's extremely costly. But the good news is that we need to understand that it can be prevented and treated. We know that the heart failure treatment is complex but very successful. And in the last 10 years, we introduced several new therapeutic strategies, both in the management, in the pharmacological management, but also in the management of heart failure with the devices, and end-stage heart failure with left ventricular assisted devices and heart transplantation. So we understand that the complexity of treatment is something which we are dealing most, and that we will be working on that in the sequences and in the years to come very vigorously. Obviously, we understood that diabetes is one of the most important comorbidity in heart failure, and having that in mind, we actually put forward the policy that treatment comorbidities is something which is the best way to treat heart failure itself, because it is halting its progression and giving us more chance how to approach to this patient. Obviously, ESC is working very hard on it. And in 2019, I had the pleasure to be the part of 2019 ESC guidelines on diabetes, prediabetes, and cardiovascular disease, which were focused on the patient with diabetes. However, we know today that the new drugs are just in the focus of our activity, and we need to understand that the treatment of diabetes is today something which we may be concentrating more and more on. However, we understand that the comorbidities are very important, but cardiovascular disease is something which kills the people with diabetes. The most important complication being peripheral artery disease, and then comes heart failure. However, we were surprised in the last 5 to 10 years that the treatment of diabetes subsequently gave us some knowledge about heart failure. So having in mind that new anti-diabetic drugs are comprising DPP-4 inhibitors, GLP-1 and SGLT2 inhibitors, I'm gonna run through all these groups to letting you know what is the combination of these drugs and the combination of diabetes and heart failure may give us in the clinic in terms of having more and more knowledge and more successful treatment. So DPP-4 inhibitors were many. We had a lot of hopes on it. However, when it comes to this group of the drugs, we may conclude that DPP-4 inhibitors, sitagliptin and linagliptin, did not cause any harm on the myocardium and have a neutral effect on the risk of heart failure hospitalization, and therefore can be given to the patient with diabetes, treating at the same time, not treating at the same time, but also thinking that they may not have the adverse event on the heart failure risk. However, one of these drugs, saxagliptin, was shown to increase the number of the heart failure hospitalization and therefore is not recommended. So there is a completely different view if you are discussing with diabetologists or if you are discussing with heart failure specialists, namely cardiologists or even heart failure specialists who have different views on this. So GLP-1 receptor antagonists, very powerful group of the drugs, which have a positive or neutral effect on the appearance of heart failure and are not associated with the higher heart failure risk. What is important for us to understand in that GLP-1 receptor antagonists, lixisenatide, liraglutide, semaglutide, and duraglutide have the neutral effect, and then they are also very useful in the treatment of diabetes in patients with heart failure. So this is one side of the coin. The direction between diabetes and heart failure is bidirectional. One entity is worsening another entity, and vice versa. And therefore, we were very happy to open the new area, and this area is open with the SGLT2 inhibitors, and you can see the sodium glucose co-transporter 2 special paper for the position as a position paper of the Heart Failure Association, which is on the second round of review, and we'll think it will be out in approximately 2 weeks. The reducing the risk of heart failure hospitalization for SGLT2 inhibitors was one of the best news we had in cardiology for a long time. Obviously, everything starts with the EMPA-REG. It was clearly shown with a high statistical significance that empagliflozin is reducing cardiovascular death and heart failure hospitalization. What can be seen as important factor is that the appearance of the heart failure, the first introduction of diuretic and onset of edema, regardless of the heart failure status of baseline, was much more improved with empagliflozin than with the placebo. And that was something which gave us the thought that empagliflozin and SGLT2 inhibitors may be used in the patient without diabetes with heart failure. These results were approved and confirmed in a CANVAS program with canagliflozin, which was shown to decrease the cardiovascular death or hospitalization for heart failure with a high reduction of the hospitalization for heart failure of the patient with these two entities associated. Even as Feras pointed out, the cardiorenal axis is extremely important, and CREDENCE trial was one who analyzed the canagliflozin in the patient with renal disease and albuminuria on RAS inhibitors. They only had 15% of the history of heart failure with a solid follow-up of 2.6 years, but it was also shown that canagliflozin was decreasing the hospitalization for heart failure in this patient. When we go to the declared TIMI-58, very important trial, which also showed the decrease of heart failure hospitalization, borderline decrease of cardiovascular death, and no effect on the MACE, it was clearly seen that in the patient with diabetes and heart failure, we have a new group of the drugs. With some of the smaller mechanistic drug trials, like EMPA-HART CardioLink 6, it was shown in 97 patients that empagliflozin was much more successful in decreasing left ventricular modeling among the patient with diabetes, with and without heart failure. Therefore, it is clearly it is clear that EMPA or SGLT2 also have the significant effect on the left ventricular size and left ventricular function. And therefore, the SGLT2 inhibitors were seen as a drug which is reducing heart failure risk, and empagliflozin, canagliflozin, and DAPA-gliflozin as being associated with a lower risk of heart failure hospitalization, where in the European guidelines 2019 seen as a drug which can have one class of evidence and level A. However, that was just the beginning, and then the tsunami of thinking and the tsunami of theories about the mechanistic effect of those drugs on reducing heart failure hospitalization in the patient with diabetes came about, leading to the DAPA-HF trial on 4,744 patients in whom DAPA-gliflozin was clearly shown to significantly and very convincingly decrease the primary composite outcome of cardiovascular mortality, heart failure hospitalization, and urgent heart failure visit, with excellent hazard ratio and with number needed to treat of 21. What needs to be seen here and needs to be understood is that there is very early separation of the treatment group, and the reduction of the cardiovascular mortality, which is shown here, was seen very early, around 3 months. In DAPA-HF heart failure hospitalization, and worsening of heart failure were clearly seen in both patients with and without diabetes. And that was the breakthrough, because the patient without diabetes but with heart failure was clearly shown to have the significant and convincing effect of the dapagliflozin on the long-term outcome. Hazard ratios were excellent, and besides of very early effect of the dapagliflozin, which is exactly what we can say now, it was shown that symptom improvement is clear. And then if you compare the patients on dapagliflozin, it was a significantly clinically meaningful change, more than 5 points in the Kansas questionnaire in those patients. The ball start rolling further with the DEFINE HF study. underlining the dapagliflozin effect on biomarkers, symptoms, and functional status, in whom no significant difference in average 12-week NT-proBNP versus placebo was shown, but clinically relevant improvement is Kansas questionnaire was again underlined. Regarding acute heart failure, and that was our question from the previous communication, small hypothesis generating randomized study comparing empagliflozin and placebo in acute heart failure, having in mind the diuretic response, length of hospitalization, symptoms, and biomarkers, shown that it was no difference in day 1 baseline to day 4 in these parameters. However, as a secondary endpoint, the significant reduction in clinical events within first 60 days after randomization was shown. That positive signal in a relative small study means that we need to investigate these drugs in acute heart failure setting. It was already mentioned that last guidelines are 2016. We were having some troubles in putting the guidelines task force together, but we are happy to let you know that the next guidelines will be released on the Heart Failure Association Congress in Florence, hopefully face-to-face or electronically. And we thought that before waiting 1 year more, it will be nice to have a clinical practice update on the treatment of heart failure. And this document was underlining the use of SGLT2 inhibitors as important factor, as important, extremely convincing results which were shown to us regarding dapagliflozin, regarding empagliflozin and canagliflozin. So we are looking at the future. In early September or late at the end of the summer, August, the Emperor Preserved will be released. Probably Emperor Reduced will follow very early. We are also waiting for Deliver and Soloist VHF to show as well. It's not easy to say what is going on only from one trial. We should be critical, we should be realistic, and we should making our conclusions based on only the facts of the clinical trials we have. We know that dapagliflozin reduced cardiovascular death and heart failure hospitalization in patients with heart failure who did not have diabetes. As you can see, it was early separation of treatment curves, which may influence the therapeutic effect. Then there is a clear-cut improvement in the functional capacity of this patient, and there is a small signal that it may, that the possible benefit on acute heart failure may exist as well. This is the big question mark for the colleagues who are in task force for guidelines, because they poses several important questions. So when SGLT2 inhibitors will be used? Do they need to be given on the top of all other heart failure drugs? Do we need to separate the different subgroups of our heart failure patients in terms of identifying the groups which will be most successful in long-term outcome on this treatment? And of course, I would like to conclude by saying that there are more unanswered questions than the really solidly founded facts. we should look at the combination of SGLT2 inhibitors and sacubitril valsartan on something like which is extremely, which may be extremely positive. But we also may look at the risk of the adverse event and interaction between the different drugs we are giving to our patient because the polypharmacy may be very important factor in deciding. Especially the vulnerable heart failure groups like elderly, frail, the patient with multiple comorbidities may be also something which may have most or less benefit, depends on what the clinical trials show. At the end, we need to wait for the other studies. But it seems to us that we look in one door, and that was the door of sacubitril valsartan, waiting for the sensational treatment of the heart failure. However, our hopes were still high, but from the small doors of the diabetologists, SGLT2 came and gave us the hope that we will have one more drug which may improve the long-term outcome in the patients with heart failure. I would like to thank you very much for your attention. So, is everybody alive there?
Yeah, thank you very much, Professor Petar, for this elegant presentation. Very interesting topic, and I think a lot of discussion and questions will be raised. We asked it before, and Dr. Firas asked about the position of SGLT2 inhibitors in the treatment of heart failure, and what do we expect from the guidelines next year. It would be which class to add this drug. Is it an add-on after sacubitril valsartan, or should be given for all patients? I think this is the very important entity for discussion.
So what is true is that we have one big solid study in whom 1A is probably on the horizon. However, we should wait for another trial, Emperor, who is going to be, as I pointed out, at the end of the summer and the beginning of the September. If that trial will be positive, hopefully in HFrEF, and even more hopefully in HFpEF, then this drug will be absolute favorite for our treatment. On the first place, what we know is that 40% of the patients with heart failure have diagnosed or undiagnosed diabetes. 40%. So out of this 60%, we may decide to whom we are going to give SGLT2 inhibitors. Having in mind a very good safety profile of this drug, we may think that first of all, the drug may be given even before, and this is one of the conclusions from our position paper, which is now under review. So the drug may be given early. We may not wait for the titration of the other drugs, what we usually do, 3-4 months, but the drug can be given at the beginning. It is obvious that the drug is working because the patient have the symptomatic improvement, and this is very important. And at the end, what are the facts? And I'm trying to summarize only the facts, not our expectations. We understand that among the dozen anti-diabetic drug, that was the first drug which showed the effect on the long-term outcome and decreasing cardiovascular morbidity in the patient with diabetes. Therefore, it is obvious that we expect from the second study, and I pointed out that the first study was the study with empagliflozin, which was the scientifically loud and statistically extremely prominent, and the same drug empagliflozin is going to be investigated in Emperor trial. So if Emperor turns positive in HFrEF, obviously this drug will get 1A recommendation. And this is something which we are looking forward. Nobody has a crystal ball, and nobody can say what will happen, but these are our expectations. On the other hand, there is a lot of controversy because, as Feras pointed out, Vericiguat is just around the corner. Victoria is very convincing. We had yesterday the late-breaking trials on Victoria, and what we can clearly say, this drug is also very important. And then omecamtiv mecarbil is one of the dreams of heart failure cardiologists as well, because it somehow underlines the contractility as an important factor. Without the improvement in the capacity of heart in terms of spending more energy. So as it was already said, we are looking at a few very important developments, and I believe that we may need to change our diagnostic algorithm and go to the specific subgroup of the patient who will benefit most from any of these drugs.
I have some questions, Professor Petar, related to your presentation. The first question, how and when to implement the SGLT2 inhibitor in patients with heart failure without diabetes? And what is the lowest GFR to be used with SGLT2 inhibitors?
So we believe, and this is one of the hypotheses we are testing now, that the drugs can be given very early. That comes also along the line that the drug was approved or seen as one of the preventive strategies in let's say preventing heart failure in general. If that is true, and we will know that in the next year or so, we should advocate the use of this drug very early. So that means you are titrating the usual drug, and then you are giving SGLT2 besides everything else. There are inherent problems with increasing significantly the number of the drugs, but we will finally find a niche in whom these drugs will be absolutely irreplaceable besides the patient with diabetes. On the other hand, eGFR around 30-40. So CREDENCE clearly show that these drugs are very beneficial for the cardiorenal axis. So we should pay attention on the AC inhibitors, on MRIs, on the level of potassium. But it seems that these drugs are affecting the neurohumoral axis and the electrolyte disbalance less than anything else.
Another question asked about the risk of hypoglycemia in non-diabetic patients.
Yeah, that's a good stuff about these drugs. So very slow, I mean very minimal level of hypoglycemia was shown because diabetologist knows that this drug is not a very powerful anti-glycemic drug. So the effect of hypoglycemia in non-diabetic patient is minimal, and it's at the level of placebo.
And the last question, in HFrEF patients, diabetic patients, which is better to combine sacubitril valsartan with SGL2 or GLP-1 agonist?
It seems that the option with SGLT2 is better because GLP-1 are excellent, but depending on the type of diabetes, SGLT2 are tackling what none other drug in diabetes is tackling. And this is the cardiovascular outcome. Acute MI and to some extent stroke and heart failure are much less in the patient with SGLT2 applied. However, GLP-1 are also very good drugs, which are also decreasing to some extent cardiovascular outcomes. And therefore, this is a sensitive question which we are going to be trained and answer in the future.
Okay, thank you very much, Professor Petar, for this excellent presentation and discussion. It's very impressive for the new anti-diabetic drugs. And I think in the near future, we will see much change in the use of anti-diabetic drugs in patients with heart failure, even
Absolutely.
Non-diabetic patients. Yeah, thank you very much.
I would agree with you completely.
Thank you very much. Before going to Professor Hadi, Professor Firas, we missed one or two questions during after your presentation. I have questions regarding the use of ACE inhibitor and ARBs in patients with CKD and acute decompensated heart failure, and what is the cutoff level for serum creatinine, which can be used safely in patients with CKD?
So in short, the key thing is whether or not patients are already on renin-angiotensin-aldosterone system blockers or not. If they're on them from before and they come in with worsening renal dysfunction, if you're not worried about hyperkalemia, it's okay to continue these medications because the hemodynamic benefit that has been established with these medications on board is important to maintain in the setting of managing acute decompensated heart failure. You don't need to stop them unless the patient, of course, is in cardiogenic shock to where you have to initiate inotropes, for example, with a significantly low blood pressure. Now, if the patient was not on these medications from before and then you're now facing a cardiorenal syndrome situation where the renal function is bad, then the risk from using these medications is twofold. Number one, initially, when you block the renin-angiotensin-aldosterone system, there is an expected worsening, additional worsening of renal function. So depending on the eGFR, you might and might not be receptive to further worsening in that renal function when you block the renin-angiotensin-aldosterone system pathway, because in the setting of cardiorenal syndrome which is related to acute decompensated heart failure, kidney perfusion is dependent to some extent on the renin-angiotensin-aldosterone system. So blocking it suddenly might affect that to where kidney function will worsen a little bit. So if the GFR is less than 30, for example, initiating these medications might be kind of dangerous. The other aspect, of course, is the risk of hyperkalemia, meaning that if you start these medications in that setting, hyperkalemia is a higher risk. But it's a variable thing from one patient to another. The key thing is that overall, these medications are not harmful to the kidneys. They're beneficial to the kidneys down the road because they improve the hemodynamics between the heart and the kidney. But the initial acute use of them might be dependent on whether or not the risk is acceptable or not acceptable. If they were not on them before. If they're on them before, I would continue.
Another question asking about the use of ivabradine in patients with acute decompensated heart failure when you cannot use beta blocker in patients who is still congested. Is it safe to give it in acute heart failure, ivabradine?
I don't tend to suppress, I don't tend to suppress sinus tachycardia very much. I mean, if patients come in with acute decompensated heart failure, and that's something we see in patients who have new heart failure because their ventricles are not dilated, the only way to maintain a cardiac output is by being very tachycardic because the ventricle is relatively small. I don't tend to suppress sinus tachycardia a lot if patients are still congested. What happens is as you relieve the congestion, the sinus tachycardia tends to kind of settle slowly with time. And that compensation phase is the right time to use a beta blocker. And ultimately, the key thing is not to discharge people on a high dose of beta blocker. The key thing is to discharge them on some dose of beta blocker and try to up-titrate that as an outpatient. There were some studies that showed that initiating ivabradine on top of beta blockers facilitate the up-titration of beta blockers, but I generally tend to use the minimum life-saving medications before patients leave the hospital to make sure that they're on them. And then with follow-up in the clinic, I take my time in up-titration and making sure they're on the right doses and the other medications. The key thing is to be on the most essential elements before they leave the hospital. So if it's a sinus tachycardia issue, it tends to resolve a little bit with compensation. And then if it doesn't resolve completely, as long as it's still sinus and not some sort of an arrhythmia, it's okay to have them just some beta blocker and then deal with it over time.
Thank you very much for us for these excellent explanations.